Just a real thanks to Dr. Patel and LSRS for having me here just to give kind of a different perspective to the SI joint. And I've really been dealing with the SI joint for quite a number of years, which I'll show, and really become a passion of mine, but a big portion of my practice. I do have a conflict in that I have worked with Mayo Clinic to design a system to really address all facets of the SI joint. But this talk will be a non-biased. So we'll briefly talk about the sacrum and SI joint and how it relates to me and trauma surgeons, acute injuries, and then what we do with those post-traumatics. I think, why listen to me, I've started doing fusions 2010, 2011, have done quite a number of them. We built this whole practice at Mayo Clinic specifically with an SI joint clinic where we see people from all over that are coming for both primaries and revisions for SI joints that have gone wrong. So we've really kind of really investigated it quite a bit. So kind of a simple slide, but it's kind of what happens in the pelvis. It's a pretzel. And whenever we see trauma in the front, whether it's rami fractures or symphyseal injuries, there is always something in the back. And oftentimes it goes through the SI joint. And this may bring back memories from Dr. Khalil and Patel's residencies with these open book pelvic fractures, and they go right through the sacrum or go right through the SI joint. And that's where trauma surgeons get right in there and access the SI joint and fix that trauma. We see a lot of injuries to L5 when you see these happen. Then you can see L5 normal on the left there, and then on the buccal fracture, you can see it kind of entrapped and hit by the impact there. And this patient does have L5 issues, and so it's right in that area where we deal with. So that particular patient goes to surgery. This is the outlet view, which we do a lot of these on. There's the S1 foramen and the neural tunnel, and we kind of navigate those screws right across there. This is the inlet view, and it's important, as Dr. Khalil mentioned, the imaging is critical. And you can see right there is the anterior indent of S1, L5 sitting right there. So you have to be behind that to avoid injury to L5. And then again, above S1. And that's the pathway that everybody has. And you have to learn to find that on fluoroscopy, or if you have navigation, you can navigate your screws in. But then we put the screws in across there, across the SI joint from the ilium. Then as you can see, as we tighten the screw down, you can see us reducing the whole SI joint and ilium back to its anatomic position. This is a really good view also of that indent of kind of where L5 is sitting to make sure that we're safe. And then this patient also had a small buckle on the other side, and we did the same thing. But what's even more fascinating is look at the hemidysmorphism he has on his right side here, where that indent is all the way back, meaning L5 is all the way back there. So you have to recognize that when you're putting in some of these implants, especially if you want to purchase that really good body of the S1 vertebral body or S2 if you're lower. And then we do these transiliac, transsacral screws, which go all the way across the sacrum, and there's that neural tunnel that is between the S1 and S2 foramen. And again, you can navigate that across pretty easily with intraoperative fluoroscopy, or you can use navigation if you're facile with that. And that's what the post-reduction inlet view looks like, and that's what his views look like post-operatively with an outlet. Here's a post-operative CT scan. You can see that SI joint and sacrum is pretty well reduced, and that transiliac transsacral screw is right across there in that safe corridor bone, and he's gone on to do well. Same thing with another lady that's crushed by a horse. You can see in the injury film, she has slightly widened on the right side and then completely dislocated on her left. And those are her images there after fixation on the right side there. But these ones that have that gross displacement, we do an open SI joint reduction. And so we're doing the lateral window, and we can see right down inside the SI joint there. And you can see the entire anterior SI joint ligaments have been avulsed off. And then when you irrigate it out, this comes out, which is a 3 to 4 centimeter thick piece of cartilage that is essentially the entire hemilunar surface of the SI joint that Dr. Khalil showed on that diagram. And so when that happens, patients get this horrible post-traumatic arthritis from the shear injuries in their pelvis. So this can be something minor from a LC1 to, these are all pelvic ring type injuries. The LC1s or APC2s and 3s all can have that type of damage. And then you get CT scans that look like this with terrible sclerosis, vacuum phenomenon, and in some cases, even an unstable pelvis on flamingo views, which is another workup image that I get. Kind of look at the SI joint anatomy to review, grossly and with specimens, posteriorly, it is extremely well fortified with a ligamentous complex in the back. And they all have different subparts, but I just refer to them as the main posterior ligaments. And then anteriorly, we have a real complex ligament structure with the anterior SI joint ligaments. And then we all know about the iliolumbar ligament, which can be a harbinger of instability, because when that pelvis shifts, you can have avulsions of that transverse process that's holding on to the iliolumbar ligament. So a little hidden thing that we look for elements of instability. And then, of course, the sacrospinous and sacrotuberous ligament complex. When you look at the anatomy of the SI joint, this is a gross specimen, and you can see that sort of hemilunar format of the anterior joint line, and that fits perfectly with that patient's cartilage that you just saw of what was completely ripped off with her dislocation. So that, and when you look inside the pelvis too, if you're anywhere near the greater sciatic notch when you're doing trauma screws, or if you're putting the SI joint implants, there is some pretty critical anatomy that you have to look out for. And when you look at kind of this iliac oblique view, that sacral plexus traverses right underneath that greater sciatic notch. And if you look at this picture, I think this also, for those of us that deal with SI joint issues, is exactly why patients are getting these pseudo radiculopathies, because that perineal division of the sciatic nerve sits right adjacent to the capsule on the SI joint. And if that capsule is inflamed, that's why they get this masquerading of a radiculopathy distally. I think, this is also another one with these transitional segments and so on. This is what we call in trauma surgery dysmorphism. And it is critical to recognize the dysmorph when you're putting in implants, because this is where I see the most neurovascular injuries are with the failure to recognize those transitional segments. And I don't typically count out the vertebral bodies to find out if they have 6 or if there's lumbralized something or sacralized something. So we simply refer to them as an upper and lower sacral segments. And dysmorphism is really common, and you have to really get the outlet radiograph to determine what is a dysmorphic sacrum. These are the 5 criteria, with collinearity of the iliac crest at the upper level of the disc space in the lumbosacral junction, obliquely oriented kind of residual transverse processes, really bizarrely shapen sacral and anterior neural tunnel exits, a residual disc space between the upper 2 sacral segments, and a very acute alar slopes where L5 will often sit. And these are, like on a lateral view, you see this huge promontory that I pointed here to, which is going to be kind of to fool some people when they're putting in lateral-based implants. And a hallmark of the CT scan, which I'll show you in a minute, is a very big lower sacral segment and a relatively skinny upper sacral segment. So when you look at these on radiographs and volume rendered or surface rendered images, you'll see that iliac crest level with the disc at the lumbosacral junction. That's number 1. Number 2, these little residual transverse processes or mammillary bodies. You'll see these really bizarrely shapen S1 neural foramina. You'll see this residual disc space that is kind of where that transitional anatomy started, and these very acute alar slopes. And those are very prominent on the inlet view, such as the bottom left, to know where you're going to put your implants. When I work up patients for, post-traumatic arthritis and other issues in the SI joint, my standard workup are APs, inlets, and outlets, with the outlet being absolutely key to look for any kind of transitional anatomy and also put those SI joints in profile. They all get the coronal oblique CT scans, which look, I don't know why people get like regular coronals, but they don't really make a lot of sense because nothing's in plane in the sacrum and the lumbosacral junction. So this view is in plane with the sacrum and allows you to really look at the pathways nicely, as well as the SI joints, and then axials. And both of those I use for preoperative planning as well. Every single SI joint patient also gets flamingo views. And this is a perfect example of why we get flamingo views, with this really incredible instability of the anterior pelvic ring, which, look at the middle view, you can see the SI joints just sclerotic and lit up in the back. And we also see, the postpartums, where this patient, has had 5 children and her pelvis hurt since the 2nd child. She continued to have children, but she's walking around with this chronic diastasis. Her poor SI joints in the back are just giving out on her. And that's another common thing that we'll see kind of in this, I call it a trauma population, because I think anybody who's had a child knows it's kind of be a traumatic event. It's also key to know that just imaging alone is not diagnostic for SI joint problems. And a buddy of mine from fellowship published this article a number of years ago. And if you look at that graph on the right, they describe degenerative changes. And if you look at the age group on the bottom and degeneration of one SI joint or major generation one SI joint, really anybody over the age of 40 to 50 is going to have some level of degenerative changes in their SI joint. So imaging alone is useless in looking at these post-traumatic SI joint issues. It's nice when it clinically correlates, but otherwise it doesn't mean much. Intraoperatively, when I do trauma, I do them supine, so I have access to the symphysis in the front, which can indirectly reduce the back. When I do them for degenerative conditions, I do them prone, and we combine them with our long segment spine fusions quite often. But prone is so much easier for draping. You just kind of operate on your head for a trauma surgeon, and this is us just doing a supine. Kind of get a stool, look at the monitor, and then this is the inlet view when they're supine, and the inlet view or the outlet view when they're supine, and you can see on the right view the images that you get with that and how the sacrum is oriented. Now, when they're degenerative, I put them prone, and this is the patient prone. That's the PSIS right up there, and that's kind of how I draw up my proposed incisions when I do these types of activities. If I'm doing, just a trauma, again, not usually like this, but in some cases you can. This is the inlet view then. Inlets are for anterior, posterior adjustments. Your beams coming down the anterior, overlying 1 on 2, and that's how you get your perfect looking right down that column. And then the opposite view, the outlet view, is going to be for cranial caudal adjustments, and the view is going to be like this. And you can see on the right, that's your adjustment. You can see S1, you can see the neural tunnel, and that's your pathway that's always there. And then if you're a little bit confused, or you just want to double check where you are, I will always recommend that you get the lateral view. You have a really good lateral when you line up those greater sac notches and they're superimposed over each other, and you want to be posterior to the iliac cortical density line and then posterior to the anterior sacrum. Again, so here's this dysmorphic, and I think as we go through this CT scan, you can see the tiny, tiny upper sacral segment pathways. And as you go down, you're really going to see the wide open lower sacral segment. So in this particular patient, we would have plenty of access to a transiliac transsacral screw or a fusion implant deep into the lower sacral segment. The normal sacrum, now you can see the normal view here as we come down and see a pretty big upper sacral segment where that could easily handle implant all the way into that body without having to go to S2, which is not possible to get anything into any type of reasonable bone. So post-traumatic patients, for me in my population, these are the patients that have these maintained screws in place. And if you have a patient that comes in and sees you in your clinic with this picture, you should just take them out and see how they do. And it's been shown in several studies that simply removing these implants across an unfused joint can give the 80 to 90% of these patients get pain relief by simply removing the implants. This particular patient, however, still had persistent pain, and injections were positive. She had incredible sclerosis, vacuum phenomenon across the SI joints, and some instability. So we offered her an SI joint fusion to take away that pain. And as Dr. Khalil said, there's a lot of implants out there. You just choose this one that works best for you and your patients. I like to use one that just completely scrapes out all the cartilage, all of the arthritis inside there, and we just scrape it out and get rid of it and suck it out. This sucks out all the debris. I bone graft it, put the screw all the way into the vertebral body to get that really tight bone, and put an anti-rotation screw below it. And then I went ahead and did her other side. And that's what she looks like when she's done. And then she gets a post-op CT scan, 1 or 2 years later, and she has, robust fusion and essentially cured her pain in the back. So it works for the right patient when they have that kind of post-traumatic deformity. And I kind of harp on compression and stability. And if you look at those top x-rays on the left, you'll see tongue and groove decking. And if you compress tongue and groove decking, you are going to get essentially instant stability, just like those histograms show on the screw there. So that gives them stability and really good initial pain relief and good healing. And then for all of this is the same for trauma and fusions. For degenerative or acute trauma, just with usually having weight bearing is tolerated right off the bat, just because of that strong stability, and then just routine imaging and CT scans. So, in conclusion, SI joint pathology is real in the trauma population and otherwise, and I'd love to get into later with the long segment fusions and adjacent segment disease, which essentially SI joint disease is the most caudal aspect of adjacent segment disease. There are other causes. Facetogenic are big ones, and then the hip is a huge one. So if they have evidence of hip disease with a hip exam, which every patient should get, then you always want to throw in a hip injection to see if the hip's causing it, because we're getting our series together of doing hip replacements and scopes and osteoplasties for femoroacetabular impingement and curing SI joint disease just with working on the hip. So anyways, we'll end there, and these are topics for some discussion later on if there's time. Thank you.